Welcome to all the participants. Here are a few reminders for you guys to take note before we begin. Firstly, please ensure that your microphone is muted throughout the session. If you wish to ask any question to the speakers, you may type it down in the chat box during the Q&A session. Secondly, please fill in the attendance or feedback form using the QR code or link that will be given at the end of the event. So please do remain throughout the talk. Thank you. A very good morning to Dr. Subramaniam Govindan, the advisor of Secretariat Sukarela. A very good morning to Dr. Subramaniam Govindan, the advisor of Secretariat Sukarelawan India University Science Malaysia, Ms. Sumithra Balasubramaniam, the president of Secretariat Sukarelawan India USM, Mr. Lakshmanan Valliyappan, the project director of MEDHEALTH 2.0, our guest speakers for today, Dr. Sumithra Appava and Dr. Jaya Muneswarao, and to all the participants who are here with us today. Welcome to our MEDHEALTH 2.0. Before I proceed, I would like to introduce myself. I am Tanuja Balakumaran, and I'll be your MC for today's event. Our topic for today would be focusing on asthma in adults and what do we need to know about it. So please sit back and listen thoughtfully. First up, we would like to invite Mr. Lakshmanan Valliyappan, the project director of MEDHEALTH 2.0, to present his speech.
Can you hear me, Tanuja?
Yes, we can.
Okay. Okay. Thank you, Tanuja. A very good morning to Dr. Subramaniam Govindan, the advisor of Secretariat Sukarelawan India USN, Ms. Sumithra Bala Subramaniam, the president of Secretariat Sukarelawan India USN, our honorable guest speakers for today, Dr. Sumithra Appava and Dr. Jaya Muneswarao, and to all the participants who are here with us today. First and foremost, I would like to wholeheartedly welcome our guest speakers and our audiences to MEDHEALTH 2.0 by Secretariat Sukarelawan India University Science Malaysia. I would like to thank all the crew members for their efforts and commitments on making this whole event a success. I would also like to thank our advisor, President and USM top management for their support and guidance in preparing for the event. We are humbled and forever thankful for your cooperation. Previously, MEDHEALTH had been carried out in two phases, which are health screening and blood donation. Unfortunately, this year we couldn't do like that due to the situation where we cannot conduct a physical event. However, we have planned to conduct blood donation program in USM itself initially, but it didn't work out since total lockdown has been implemented. So this is the reason we have come up with this health talk session. So the main objective of MEDHEALTH 2.0 is to increase the awareness and the ways to improve health of the public as well as their family members. The knowledge and skills on this aspect should be emphasized to them as the younger generation should be educated on the importance of healthcare from an early stage. Parents' awareness are also very important to ensure that healthy lifestyle practices can and should be practiced. Therefore, from this session, I hope all of you can learn about asthma in adults and what do you need to know about it. I hope that this session would enhance your knowledge about asthma so that you could take precautionary steps if something similar happens to you or your loved ones. Thank you and have a great day.
Thank you for your speech, Mr. Lakshmanan. Joining us today are two fantastic speakers who are experts in their fields. Dr. Sumithra Appava, internal medicine physician from Hospital Kepala Batas, Pulau Pinang, and Dr. Jaya Muneswarao, Pegawai Farmasi UF54 from Hospital Pulau Pinang. First and foremost, let me start with Dr. Sumitra's introduction. Dr. Sumithra is an internal medicine physician who obtained her MBBS from Kasturba Medical College, Manipal, India in 2011 and also her MRCP from the Royal Colleges of Physicians of the United Kingdom in the year 2016. Dr. Sumithra is currently working as a physician in Hospital Kepala Batas, Pulau Pinang. She was also the medical officer for the Department of Internal Medicine in Hospital Sultan Abdul Halim from the year 2013 to the year 2016. Not only that, but she was also a gazetting physician at Hospital Raja Perempuan Zainab from 2016 to 2017 and also at Hospital Tanah Merah in the year 2017 till 2018. She worked as a physician in Hospital Tanah Merah from 2018 to 2019. She did a subspecialty rotation in multiple fields such as respiratory, nephrology, and endocrine. Plus, she organized a medical update on hypertension and thyroid disorders at Hospital Tanah Merah in 2018. She was also a speaker at Khusus Pengurusan Dengue Negeri Kelantan in 2017. Besides that, Dr. Sumithra was also the committee member of Infectious Diseases and Chemotherapy Conference 2017, a speaker at Kursus Update Diabetes and Tuberculosis 2017, as well as in the HIV Update HPRZ2 in 2017. Moreover, she was also involved in teaching medical students at Lincoln University and gave multiple lectures at Nursing College Kota Baru. On the other hand, Dr. Jaya Muneswarao is a pharmacist with a special interest in respiratory medicine. He obtained his PhD in clinical pharmacy from University Science Malaysia in 2021. Dr. Jaya is the current head of the Medication Therapy Adherence Clinic at Pinang Hospital. On top of that, he was also the former vice president of the Clinical Pharmacy Working Committee, Respiratory Subspecialty, Pharmaceutical Services Division in the Ministry of Health. He is also an invited reviewer for international journals such as Respiratory Medicine, International Journal of COPD, and Journal of Asthma. Likewise, Dr. Jaya has presented his research at many conferences and won several awards such as a Best Oral Presentation at the Malaysian Thoracic Society Annual Congress, 8th National Pharmacy R&D Conference, and Kedah Pharmacy R&D Seminar. In addition, Dr. Jaya is one of the authors of the Malaysian Clinical Practice Guideline for Management of Asthma in Adults. In 2018, Dr. Jaya was appointed as an advisor for Asthma Malaysia, a prominent asthma education platform in Malaysia. He is also a member of Malaysian Thoracic Society Inhaler Education and Training Steering Committee. Hence, his interests include asthma or COPD pharmacotherapy, pulmonary drug delivery, inhaler devices, tuberculosis, and patient-centered care programs. Without further ado, let's welcome our guest speakers of the day, Dr. Sumithra Appava and Dr. Jaya Muneswarao. So, doctors, let's begin our session for today. Our first question for today: what is asthma? What are the symptoms of asthma? Dr. Sumithra, can you explain it to us?
Hi, good morning to all participants who have joined us today. Good morning to my co-speaker, Dr. Jaya, and to all the organizing committee. Good morning. It's a pleasure being with you here today morning. As you all know, I am Dr. Sumithra. I am a physician now working in Hospital Kepala Batas, and I will be here to just share a little bit on just the basics of asthma and hope that we can get some key take-home messages with us when we are done. So the first question is, what is asthma and what are the symptoms of asthma? So I think that most of us will be familiar with the term asthma, and most of us will be familiar that we may relate it to some kind of respiratory symptom, or we may relate it to respiratory per se. That means some problem with the lungs. Actually, from a medical point of view, when we say asthma, it is actually a chronic problem, a chronic disease of our airways, more specifically bronchial hyperresponsiveness, which means that our airways are actually becoming hypersensitive to variable stimulus, which actually normally in normal people without their airway problems of airway diseases, this stimulus does not cause the airways to be hyper responsive or more sensitive in normal individuals. So the sensitive, so for those individuals who are sensitive and they have this hyper responsiveness, and it is a chronic problem, it is variable and there are multiple symptoms, and this is what we label them as asthma. So actually, when we speak about asthma per se, there is no clear or very precise definition of asthma, because as I said, it's chronic. The progress is waxing and waning, and it typically occurs variably over a long time. But the most common symptoms that we are familiar with when we are dealing with asthma is usually, the most important is 3 symptoms. Number 1 is wheezing, which I think most people will be very familiar with. So wheezing is actually when you have what I can describe in a simple terms as musical noises of different pitches, or when we actually typically when we are asking patients or what will be like, do you have any hui hui sounds, this kind of things, especially when they are trying to exhale their breath. So this is what we say as wheezing. And also the second symptom, which is cough. So cough, we are familiar with it. There's different types of cough, dry cough and cough with sputum production. And cough can also be more present when we are lying down, we are sitting down and etc. And the third symptom will be dyspnea, or actually in simple terms, it's just shortness of breath. So we have three major symptoms which are related to asthma, which is wheezing, cough, and shortness of breath. So of course, these are the basics, and asthma actually can happen to any age group, from children and up to the adult age group. Although commonly we do tend to see asthma more in the childhood, although that is more common, we also do get adults who are diagnosed with asthma after they have reached adulthood, means that they did not have symptoms of asthma as a child. Other than these symptoms of asthma, sometimes patients do present to us with other symptoms such as chest tightness, or sometimes they may not present with all the three symptoms that I mentioned, which is cough, shortness of breath, and wheezing. Sometimes they may only present with wheezing, sometimes they may only present with cough, and sometimes patients, very rarely, they do not have much symptoms at all. So I think back to you, Ms. Tanuja.
It was a clear explanation, Doctor. Thank you, Doctor. Moving on to the second question. How is asthma diagnosed? What do you think about it, Doctor?
Okay, so as I mentioned earlier, just was a brief introduction about what was asthma. So as we know, it's a chronic hyper-responsive state of our airways. So actually, before I mention how is asthma diagnosed, maybe I will just briefly explain how do you get asthma? I mean, what happens when you have what is known as an asthma attack, or what is this hyper-responsiveness that I'm talking about? So as we know, our airways, they are lined by membranes, and when there is some stimulus, when I mean about stimulus, so these are what that later on we will be discussing further also. There are some things that can trigger or make us more prone to develop this hyper responsiveness. So for example, I will just give one example. If someone is sensitive, or perhaps they have allergy to dust, and so they are exposed to this dust. So what happens is their airways, they start to narrow because there's a lot of mucus production, and the airways start to bronchoconstrict. Bronchoconstrict means it's just become narrow. So the airways start to narrow, and that's when patients have difficulty in breathing, and they have the symptom of difficulty in breathing, especially when they are trying to exhale the breath. So when we are breathing, we know that we do inhale and exhale as well. So in asthmatics, they have difficulty to blow out the air that they have already got in, and thus they have the feeling of breathlessness. So with this being said, how do we diagnose asthma? So of course, when it comes to any medical problem per se, we follow a certain way where we go by, we take history, which means we ask a lot of questions to the patients, and then we examine them, and then we will determine what are the investigations that we need to do for them, and then we will come up with a plan of treatment for them. So for asthma, actually, when I was talking a lot about asthma and saying how it's a respiratory problem and how the airways are being narrowed, and this causes the airways to narrow and cause all the symptoms. But there are a lot of other situations or other conditions itself which can actually mimic our asthma, which we think it is asthma, but it is not. So that's why things like our history taking, where we actually patients may think that doctors are bombarding them with a lot of questions, but actually when we ask these questions, our aim is actually to differentiate between the many diseases which actually can be either respiratory problem or even non-respiratory problems, which actually can present like asthma and sometimes may unfortunately be misdiagnosed, and patients may be wrongly treated as asthma, or they are not diagnosed and not given a proper treatment of asthma. So usually during the history takings, we may ask their history of having childhood asthma symptoms. So usually this is quite important because usually when they have had asthma as a child and being treated and all that, so we know that this has some childhood origin. And usually we also inquire about the family history, whether there's any other family members who are having asthma, maybe maternal or paternal or any of their siblings having asthma. And also we try to find out how long they've been having the symptoms. Typically, it is, as I mentioned, it's more common to develop asthma since childhood, which may have a remission period in between when they hit puberty up to adulthood. But we do see some unusual cases where they do develop asthma in their adulthood, and that could be due to many number of other reasons. The other things that we also look in the history is importantly, what are their occupation? Because as we will discuss later, some occupations which are more prone to being exposed to dust, sawdust, and this kind of industrial dust, some patients may be more symptomatic. So actually, when we probe deeper and we ask them, do you have symptoms actually when you're at work? Do you have them on your off day at home? Sometimes they realize that actually the symptoms actually just manifest when they're at work. And when they take leave or when they take a short break from work, they notice that actually they're feeling much better and do not have symptoms. So these are kind of thing we label as occupational related asthma. Some people may be more prone. We will also inquire things like, do you get more symptoms when you are doing exercise and things like this. We will also look into their body mass index, their weight and their height, etc. So then coming to the next part, which is examination, usually we will examine them. Most of the times when we see patients in outpatient clinics, patients are usually well at the time when they come and see the doctors. Because usually when they are having an acute asthma attack, they most likely would have gone to the emergency, most likely would have received some treatment such as nebulization, or some inhalers would have been given or purchased by them from the pharmacy. And usually when they see us in the clinic, they are not really having an acute attack. So sometimes our examination actually cannot give us a lot of information at that time, because only when they're having an acute attack, you may see them being actually breathless, or you may see them having bouts of cough, or when you auscultate, when you listen to their lungs, you may be able to hear the rhonchi, which is the wheezing sound that we mentioned. That's we hear it as rhonchi in the lungs. But nevertheless, we do have investigations and things we can do. So basically what happens is, when we see the patient, we speak to the patient and we get a picture in our mind and we think, okay, this can be possible asthma. We examine the patient and we will proceed further to run some investigations. So we will be doing blood tests, especially like your full blood counts, to look for your eosinophil count, because eosinophilia has also been said to be one to be related with asthma, especially in the eosinophilic type of asthma. And also we may order a chest x-ray, but I won't say that chest x-ray is the most crucial investigation, because as I mentioned earlier, when patients do come to us, they're actually quite well, and we don't expect to see much abnormality in the x-ray anyways in an asthmatic patient. Probably just that their lungs may be hyperinflated, but it won't be very much useful to us. We do have other tests. If anyone is familiar or had ever gone under evaluation for lung problems or lung respiratory problems, we have something called as a pulmonary function testing, or we call it as a lung function test, which we do in hospitals, some clinic kesihatan, where you are required to blow into a machine. This is connected to a computer, which can actually read your lung volumes. Means what they will ask you to do is actually take a deep breath and forcefully expire your all your breath out within 1 second. And all these things will be recorded in the computer and printed out as a test result. So basically why we are doing this is actually we can see uh, how much of we can get some ratios actually, which is your expiratory volume ratio in 1 second over the vital capacity of your lung. Basically, in simple terms, what this tells us is what kind of respiratory problem do you have. Typically, there are two main types, which is obstructive and restrictive types. So asthma is actually more of an obstructive airway problem. So when we get the results from the lung function testing, and it is actually correlating with the obstructive defect. So this is actually in favor of what we were thinking, which is asthma. So if your lung function test comes out as something else, for example, a restrictive lung problem and all that, so we won't be thinking so much of asthma. Probably we need to go and look into other things or other problems, and we probably need to do some other tests. Another important test that we also do, that is an extension of our pulmonary function test, is actually we do the test and then we give an inhaler to the patient. We ask them to inhale the drugs, and we will repeat back the pulmonary function test after about 20 minutes. And we see whether there's an improvement after the drug has been administered to the patient. So this is what we call the reversibility of the constriction in asthma patients, reversible. So it means that to some degree after the drug actually can cause the dilatation of the airway after that it has received the drugs, and then we can see in your FEV1 value would have increased by more than 12% or more than 200 mLs of volume. Then we will know that okay, this is responding to the treatment, and based on all the history and examination that we have done, this is more in favor of asthma. So I think that's pretty much the basics on how asthma is diagnosed. But also to just say that again, just because somebody is having wheezing, cough, or breathlessness, it doesn't mean that it's asthma, especially because we deal with mostly with adult patients. I'm an adult physician. So we are more cautious when we are diagnosing patients in asthma, because there are a lot of other differentials that we need to think about. For example, if you have someone who did not really have any asthma in their childhood, and who's actually a smoker, who has been smoking maybe every day for the last 10 to 20 years, and now is coming with symptoms, with the same symptoms, actually cough and wheezing, and even their pulmonary function testing may show an obstructive, we would be more inclined to think that this particular patient may be more correlating with a chronic obstructive pulmonary disease, which is actually related closely to his smoking habits. And also interestingly, we find that a lot of patients are actually misdiagnosed with asthma, especially elderly middle-aged women. They may have some known or unknown heart problems. They will be having coughing, and they will be having some wheezing. If you notice, their cough will be more at the night time, which is also found in asthma. And also you may notice that when they're lying down, actually they are coughing more. So when you look more into these things, actually this lady does not have asthma, but actually she's in heart failure. And actually the symptoms are almost the same and almost mimicking asthma. And some of these patients receive wrong treatment. They receive inhalers and all that. And this is what sometimes in the medical terms we call it as a cardiac asthma. So actually this group of patients are treated wrongly with inhalers, and actually their symptoms do not really improve because we are not treating them correctly. At the same time, there are also patients who only present to us with cough, and sometimes we miss out the diagnosis of asthma because we are looking for things like wheezing, we are looking for things like shortness of breath, which they may or may not have, only the symptoms may be due to exercise and such. So I think that's just briefly about diagnosis of asthma. Yeah, Ms. Anuja.
Yes, doctor. I agree to the point as well. Let's proceed to the next question. Is asthma contagious? how can someone get asthma? Dr.
Okay,
Sumithra?
the good news is unlike COVID-19, asthma is not contagious. So that's a relief. So how can someone get asthma? I think that's a very good question. So actually, asthma, as I mentioned, it is more common to see this in pediatric age group. A lot of asthma is actually, when studies have been done, they have found that there are some genetic predisposition to get asthma. There are a lot of genes and multiple gene theories and everything has been studied and come out to say that there are some genes in people that makes them more predisposed to get asthma. The second thing is, of course, their family history. Having a strong family history of asthma also may be more predisposing for a person to also be an asthmatic. And also, interestingly, there are some perinatal and some other features, like they have studied those babies whose mothers were smoking when they were pregnant. And they have found that these group of babies actually grew up later and were more prone to be asthmatics as an effect of their mother's smoking when they were pregnant. Also, some babies who are born premature or actually very premature with problems, complications like chronic lung disease and all that, they may be more predisposed to get asthma as well later on in life. When it comes to adults, actually the important factors, actually when we see, if we want to see gender wise, males are actually more predominant to get asthma, especially in the age group of less than 10 years old. And in adulthood, actually, is more commonly seen in females and especially in the obese population, of body mass index more than 30. And these people also can present with a subset of dyspnea, which is something similar to that of asthma and can also predispose them to actually getting asthma. Um, and also in adults, the other way that somebody can actually get asthma is if they are having some hypersensitivity to food, or they are being triggered by dust and those other triggers that we will speak about later. And also the most important thing that sometimes get missed out is their occupation. A lot of the times we actually see that when we investigate, um, we find out that actually it's their occupation that sort of triggers the asthma. And actually prior to that, or when they're on leave or when they're away, they're actually quite well. And actually another thing is seasonal also. Some people tend to have more asthmatic symptoms when it's the weather is more cold, the air is drier, and etc. Yeah.
Wow, that point seems really important, Doctor. Thank you, Doctor. Now let's move on to our next question. What is the meaning of good asthma control?
Okay, so of course, the most important things, I think so far, whatever I spoke about diagnosis and all that, maybe not won't be so interesting or relevant to those who are actually having asthma, because probably that's more of our job as doctors to diagnose the patients. But the important thing for those who are having asthma or those who are looking after people with asthma is actually they want to know about their, because asthma is actually a very debilitating disease, because the feeling of breathlessness, the helplessness, and they will not be able to go about their daily activities as usual. So for them, actually having a good asthma control, that should be the aim. And that should be what our treatment and everything is targeted for, so that they can have a fairly very good quality of life, and they're able to do everything that they wish to do without having all these symptoms of breathlessness, wheezing, and exacerbations just interfering in their life. So when we speak about good asthma control, so later on, I think my colleague Dr. Jaya will be speaking more on the treatment aspects. But actually, when somebody is treated, when they come to our clinics, and how do we assess them is actually we ask them how are their symptoms, and then we decide how is a good asthma control. So actually there is a asthma control test, which I think may not be so visible here, but actually we can just it's available online. It's something known as ACT, or asthma control test. So actually ideally this should be done for every asthma patients every time they visit a doctor. At doesn't matter even if it's a hospital, clinic, and even patients can do this on their own in their house, because it's just as simple as answering 5 questions. So the questions that we ask is actually in the last 4 weeks, which means in the last 4 months, how was your symptom control? So how much time did the asthma stop you from getting your work done at school, at home? How often do you have shortness of breath? And the answers can be like more than once a day, and not at all. So its answers are given 1 to 5. And the lowest answer, which point number 1 will be very poorly controlled, means like, for example, if they say during the past 4 weeks, how often have you had shortness of breath? The number 1 answer is more than once a day. The second one is once a day, and the fifth one is not at all. The same thing, we also assess symptoms, that is wheezing, coughing, shortness of breath, chest tightness, especially during the night or early morning when they wake up. So these are the things that we really look for. How is your night symptoms? How is your cough at night? How is your cough when you wake up? Are you having them more than twice a week? Okay. And we also ask, how often are you using your medication? So later you will find out that in asthma, there's medications which are used for relieving your symptoms, and also medications which are used for maintenance to prevent another attack from happening. So we ask, how many times have you been using your reliever, which is your rescue medications? Is it more than 2 times a week? So you will be answering these questions. So actually, when you do this test, even if you do it yourself at home, actually, when you see that there's a score, the total score is 25. So 25 is a full score. If you have a score of more than 19, it means your asthma is possibly well controlled. If it is less than 19, it means that possibly your asthma is not so well controlled. Some improvement can be made. You maybe need some step up in therapy or some other changes. And if your score is less than 15, actually, this shows that your asthma might be very poorly controlled, and probably you and your doctor will need more discussion to optimize your treatment. So actually, when you use your reliever medication more than 2 times a week, means you are needing it 3 times, or maybe using it 3 times a day. That means like maybe 4 to 5 times a week. This is the simplest way to know that your asthma is not actually very well controlled, or previously it could have been well controlled, but now maybe you need some adjustments, probably in your routine or in your medication, etc.
Thank you, Dr. Sumithra, for your wonderful sharing. Let's proceed to the next question. How is asthma treated in adult patients? Dr. Jaya, could you explain to us more about it?
Yeah, sure, of course. First of all, I would like to thank the organizing committee for this wonderful invitation, and also thank you for the kind introduction. So we have to appreciate whatever Dr. Sumithra has explained very detailed, and now we understand that asthma actually is not curable, but with the right treatment, it can be well controlled, and patient can live a normal life, which means they can do all their daily activities without any interruption. And that is what actually we want. When we see someone outside there, we should not actually identify, oh, this patient having asthma. No, he should be living a normal life with treatment. And nowadays we have very good treatments, and we can actually achieve that. So the backbone of asthma treatment is inhaled steroids. They are in inhaler form. Inhaled steroid work by reducing inflammation and swelling in the airways, so you can breathe better. These inhalers are known as preventers or controllers. The name explains. They should be taken regularly every day. Bear in mind, in your mind, that you will not see the improvement in your asthma straight away. It may take several weeks to see the benefits. But I assure you, if you keep taking your preventer or controller inhaler as prescribed and continue to take it even when you feel better, all the benefits will start to happen. Sometimes, depending on asthma control and severity, we add an agent called what we call long-acting bronchodilators. Nowadays, it comes in a combination with a steroid, which act to relax and open the airways. This is actually now we do not use separate inhalers for as we usually combine it together, and the manufacturer also all the production they do combine 2-in-1 inhaler, a steroid with a long-acting bronchodilators. They usually come in one single inhaler. And asthma patients are also prescribed with another type of inhaler called the reliever inhaler, or known as the blue inhaler, popularly known as the blue inhaler. I think I have one here. You can see this is very common, very popular one. Okay. For example, salbutamol or terbutaline. These inhalers are fast-acting and taken when necessary only. For example, you take them to relieve your symptoms during asthma attacks or flare-ups, or also before exercising. Relievers can quickly relax the muscles surrounding your airways. The airways can then open more widely, making it easier to breathe again. So everyone who has asthma should have a reliever inhaler and have it with them all the time. But I want to highlight a very important point. Your reliever inhaler only provide symptomatic relief and does not treat the underlying problem, which is inflammation. So the inflammation is still there. So you must keep an eye on how often you are taking your reliever inhaler. If you are taking it often, and let's say you see a trend of increasing number of puffs, like what Dr. Sumithra explained earlier. This week I use 2 puffs a week, 2 times a week. Next week I'm using 3 times a week. The following week I'm using 4 or 5 times a week. Then you know your asthma control is getting worse. This could be a sign that asthma is not well controlled, and I think this is quite dangerous. I tell my patients same thing. If you are using your reliever inhaler more than twice a week, meaning your asthma is not well controlled, or if you have asthma attacks or flare-ups, then it's not well controlled. Nowadays, for adult patients, we do not give reliever alone treatment, no more. Even in the mildest asthma, we do not give patients, adult patients with asthma, we do not give reliever treatment alone, meaning no more the blue inhaler alone. All adult asthma patients should be treated with a steroid-containing inhalers. Some patients may also receive a single inhaler, which can act as both reliever and controller. For example, I think I have here Symbicort Turbohaler and also MDI Foster. So I think I have one. This is actually MDI Foster. You can see the pink color one. And this is a Symbicort Turbohaler. I'm not sure you can see it clearly. And these inhalers can be taken regularly every day, and the same inhalers can be used to relieve the symptom as well, meaning you don't need to use a separate reliever inhaler. However, this approach is just another option to treat your asthma. Your doctor may still ask you to use Symbicort or Foster as regular controller and prescribe a separate reliever inhaler. It's all depend on the patient's condition. Okay. You may realize that I say inhale medication here, meaning the main mode of treatment in asthma using inhalers. Inhale medication goes directly to the lungs. The delivery of medication by inhalation is more effective and causes fewer side effects compared to the one you take via mouth without pills. Sometimes your doctor might add tablets such as Montelukast on top of your regular inhaled medication for long-term use. And that's sometimes when the patient has other situation that coexist with asthma, because sometimes we have other diseases that, they are good friends with asthma, maybe like you have allergic rhinitis, nasal polyp, eczema. So sometimes these Montelukast tablets, even exercise induced, they have some shown benefiting these good friends of asthma as well, and also improve asthma control overall. Okay. During asthma attack or flare-up, you will receive steroid tablets, but that one is only for few days, not for long term. Well, if you ask me those days, yeah, when patient we really give up, we can't do anything much, we tend to give a low dose steroid in tablets for long-term use. It's still in the guideline, but nowadays we do not really, I can't see many of my patients on long-term oral steroid pills. I think maybe got one or two, because the reason is oral steroid pills have higher side effects. So we don't want to put the patient into that risk. And the most importantly, we have so many good inhalers now in the market. We have so many ways to achieve good asthma control. And if you're very, very bad asthmatic, you really can't control with your standard inhalers. We also have biologics now, in respiratory center, the place I work in hospital, we even give biologics like omalizumab, but we need to really look at what kind of phenotype you are. Usually omalizumab we give for severe allergic asthma, and now in the market we also have mepolizumab, which is actually we give for severe eosinophilic asthma. So we do a lot of phenotyping in our center, and then we try to give these biologics. So there's really reduced need to put a patient on long-term oral steroid or long-term steroid tablets. We don't really need to do that nowadays because we have a lot of good asthma inhalers and other medications which proven to have a very excellent efficacy or effectiveness but reduce side effects. But during an attack, during an acute event, yes, you need to take these oral tablets for a few days, but it's only for a few days. Your doctor might give it for about 3 to 5 days. Usually we give about 5 days. All right. But I need to tell you something. Something interesting is happening in the latest asthma guidelines since I think 2019. I have published a paper on this describing what is the changes. Actually, some steroid containing inhalers can be taken only when a patient has asthma symptoms, meaning as needed basis. But meaning when you have symptoms, you take it. When you don't have symptoms, you don't take it. All right. That is new to you guys as students also, so I think many of the textbooks need to change because we understand that inhaled steroid need to be taken every day, correct or not? Most commonly twice a day. You have symptoms, you do not have symptoms, you take it. But since 2019, there is a change, interesting thing happening now is there's a guideline change say that, okay, some steroid containing inhalers can be used in this way. When the patient has symptom, the patient takes it. No symptom, no need to take. But I have to caution you on this because this strategy is not for all asthma patients, only for very mild asthma patients. Meaning you do not have frequent symptoms and no asthma attack or flare up before, you are having very mild asthma. So it's not for all. Very mild asthmatics, there is an option to do this approach. Okay, but I have to remind you again, not all steroid containing inhalers can be used this way, only certain types. And probably the most important thing, make sure your doctor has asked you to use this inhaler this way. You don't do it yourself. Right? If you have to take your controller or preventer steroid every day, let's say probably you need to still maintain that way, so because you're not, maybe you're not really you don't fall into the mild asthma category, and most of the patient actually have to take it this way. So I just highlighted this because this is something new, has changed since 2019. And our Malaysian guideline, we actually published this in 2017, and we did not include that because the guideline, the major international guideline changed in 2019. So, but why I'm telling this, because sometimes you may read in the, you may Google and you might find, oh, there is approach, but I have to caution you, this strategy is only for mild asthma, all right? If not, you have to take your inhaler controller or preventer steroid inhalers every day, even when you feel well. That is, I think, you need to highlight this. Even when you feel well, you need to take it, and this is for most of the patient. Okay, so in general, this is how asthma in adults been treated. Okay, back to you, Tanuja.
Thank you, doctor. Those facts are really something we should take note of. Doctor, you have mentioned just now about inhaled steroids, right? People have a lot of misconceptions when they hear the word steroid. What do you want to tell them, doctor?
Yeah, I agree. First of all, I would say don't worry. Asthma treatment are generally safe because they are mainly taken in inhalation form. And most of them have been around for so long. So we know the safety profile is excellent when we are taking asthma treatment, the inhalation steroid in an inhaler. And we know that your doctor will try to find the lowest dose for your medication, which able to keep your asthma under control. And this is a safe approach we do. Yes, you're right. I think the word steroid is making a lot of people worried. They're getting nervous. So you're not alone. And they are not alone. But it might help you to know that the inhaled steroid we use to treat in asthma are completely different from the anabolic steroid, which have been abused by some bodybuilders and athletes. So I have patients who, when first time we start inhaled steroid, they will ask me, if I take this, will I become like a bodybuilder? A female, obviously. For male, I think we didn't mind. I don't mind looking like a bodybuilder. But females, they am I going to develop muscle? My friends in Facebook, they, nowadays Facebook and WhatsApp messages like primary reference, right? So they read this and they tell, am I going to put on weight? Am I going to become big, bulky? I'm not going to get, I'm not going to be able to get boyfriend. I'm not going to be able to get married. All these misconceptions exist. So we have to tell you, I mean, those are anabolic steroids. There are many types of steroids available, Um, in fact, the steroids we use in asthma treatment are what we call corticosteroid. Actually, our body also produce something like this naturally as well. This is very useful steroid. Some of my patient think they can get addicted to inhaled steroid. Sometimes they will tell, oh, you take this inhaled steroids, you get addicted. Then after some time, you develop tolerance. You need to be like clinched into this inhaler forever for your throughout your life. Well, this is not true. There's no study show that you're going to get addicted. There's no study show that you're going to develop dependence on this. It's just asthma, like what Dr. Sumithra mentioned, the treatment approach, we will step up and step down. So stepping up, we start low with fewer inhalers. When your asthma is not controlled, you're getting exacerbation, your symptoms are not good, we will step up. We will increase the dose or we will add new inhalers. As you become a better, you're symptom free, you have no risk of exacerbation, you are quite well, then we can slowly, we will do it. You don't do it yourself. Huh? I mean, let this job, let the healthcare professional handles this. So we can slowly step down. We can reduce the dose, we can reduce number of inhalers. So it's always a step up and step down approach. So there's no reason to fear that you're going to get addicted to these inhaled steroids. I think that's one of the very common misconception exists, especially in our local population. But however, with all this misconception, I tell you, inhaled steroid, they have great benefits. They are generally safe in normal doses and tend to be the most effective asthma treatment. Well, the common side effects of inhaled steroid are fungal growth in the mouth and hoarse voice. We do see that. But good news is these are completely avoidable with good inhaler technique, and you must rinse your mouth with water, spit out after taking the inhaled steroid. Sometimes I do recommend to use spacers or holding chamber with MDI. I think I have, yeah. This is a spacer and the example of spacer. So this can be used with the MDI. This is a metered dose inhaler, or what we call MDI. So they tend to reduce the risk of developing these side effects. But no matter whether you use spacer or use the inhaler directly, you still need to rinse your mouth, gargle, and spit it out if you're taking your steroid inhalers. If you have any concerns regarding the medication side effects, I recommend you speak to your doctor or pharmacist. Don't speak to your WhatsApp group colleagues, or if they are doctors or pharmacists or healthcare professionals. I think they should direct you to appropriate source. And do not just stop taking the medication without consulting your healthcare professionals. Okay. All right, Tanuja.
Yes, doctor. This sounds like a point that everyone should pay attention to. Thank you, doctor. So the next question is, how important is good inhaler technique and adherence to medication?
Okay, this is my favorite topic. I can talk about it like few hours, but I don't want to bore you to death. So I will make it as short as possible. The short answer, very important, extremely important. Two important key elements in ensuring success of asthma treatment are patients' adherence to medication and correct inhaler technique. Actually, many studies showed that asthma patients fail to take their long-term treatment as prescribed. Poor adherence to long-term asthma medication is associated with poor asthma outcome. This is proven. You see so many research being done, and they all come to the same conclusion. You're not taking your asthma controller or asthma preventer inhalers regularly as directed, you're going to have poor symptoms, you're going to end up in the wards, or you're going to end up emergency department getting the treatment because you are having acute asthma attack. And we do see this scenario very often in our practice. For example, a patient may underuse the steroid inhaler, but regularly taking the reliever inhaler. This is because the patient does get immediate relief with the reliever inhaler, because once you take it, within 5 minutes, you see the effect. But steroid inhalers, most of them will take longer time to see the effect. But now some of the inhalers, the combination inhalers with the one bronchodilator and a steroid inhaler, this bronchodilator is also very scientifically designed, where it is long acting, it acts like 12 hours or 24 hours, but it also produces quick relief as well. So there's 2-in-1 again coming. Some of the inhalers are also in that way. But in generally, if you're taking the blue inhaler, this one, many patients loves it because they say, I take this, I feel relief. But you give me the steroid inhaler, I'm taking it, but I don't feel relief at all. So actually we have to tell them, you're not going to see the relief today. The benefit's going to happen after some time. You take the steroid inhalers. The blue inhaler is just going to make your airways open bigger and give symptom relief. That's it. But it does not really target the underlying inflammation. So the inflammation is always there. Okay, let's say you go let's say you got a tooth cavity, right? To take, and there's a cavity there. You go to the dentist just give you painkiller and ask you to go off. What will happen? You take the painkiller, your pain goes away for a while, but the cavity is still there. You need to go back to the dentist, right? So that's why the same thing, the reliever, you just give a relief, that's it. But the problem, the underlying inflammation, only the steroids, the inhaled steroids can tackle that problem. So for that patient, by right, should take steroid inhalers every day to control the inflammation of the airways. As your asthma gets under control, then the need to use reliever inhaler will decline. So hopefully, if my patient tells me, oh, actually, I did not use the reliever inhaler at all in the last few weeks of last month, I feel very happy, because that means the patient did not even touch the blue inhaler. That means the asthma is well controlled. And that's usually those things will make me happy. I think Dr. Sumithra also will agree with that. If a patient is unable to follow the prescribed regimen, let's say the lifestyle is too busy, sometimes we tell the patient, you need to take this twice a day. You have to take it in the morning and in the evening. And the patient say, actually morning I cannot take. I'm working, it's really difficult to do this. Don't worry. Speak to your doctor or healthcare professional. There are many ways we can modify the regimens to suit your lifestyle. Now you are patient, we also can negotiate with you. We do in our practice what we call shared decision making, where we also negotiate with patient. Okay, you cannot take it in the morning. Why? Or you're working. Okay, let me see whether we can change from twice daily, maybe once daily. If that inhaler allows it to be used as once daily, we try multiple ways to adjust this because we try to be flexible as well. Okay, some of the patient they are very open to discussion, but obviously some might not want to have any discussions. They just want to follow what we say. But I think in our practice we are starting to adapt shared decision making process more aggressively nowadays. On other note, poor inhaler technique leads to poor asthma symptoms and also increased risk of you getting an asthma attack or flare up, and also may contribute to more side effects. It is common for patients to use asthma inhalers wrongly, So by default, I know if a patient showed a very good technique to me using all these inhalers, I'm like, wow, that's excellent. Because usually I expect the technique is poor. And that is also not Malaysian problem. I think it's globally in even developed countries like UK and Europe, even in Japan, they have showed the same thing. Many patients, they use their asthma inhalers wrongly. So using the inhalers correctly will help you the right amount of medication into your lungs. It can really make a difference to how well your asthma is managed. You need to remember, I always tell this to my patient, it's just not inhaling, but inhaling correctly. Like you can imagine you give someone a Ferrari, Ferrari, right? But that person doesn't know how to drive a car. Not going anywhere, right? Same here, you can give the best inhalers to our patient, but if the patient doesn't know how to use it correctly, the medication will not work. The patient may not get full doses of the medication, and obviously it will be the waste. So someone asked me before, what is the most expensive inhaler that you have given to a patient? So to be philosophical, I think the most expensive inhaler is the one that patient is not using correctly, because that is a pure waste. Instead of reaching the lungs, the medication might be hitting at the back of the throat or staying on the tongue or mouth, but I think I will want to take this opportunity to ask patients, please show how you are using your inhaler to your doctors, pharmacists, or nurses whenever you visit them, so they can check your technique. I know sometimes some patient will tell me, oh, bulan lepas you already asked, this month also you want to ask. I am very good using the inhalers, but I will tell the patient, I'm getting salary, sometimes, to justify the salary that I'm getting, I need to do this. I need to check to make sure the technique is okay, to make sure that your asthma is good, well controlled. Because studies show that patients actually have a very short memory when come to inhaler technique. So there are two papers interesting done by some of my colleagues in Australia. They show that anything from 1 month to 3 months after the initial education, inhaler counseling that we give, patient will forget. So actually, by right, every 3 months you should review patient's inhaler technique, even though they claim, oh, I use it for a very long time, So we tend to take a lot of quit smoking opportunities. We advise patients on quit smoking in our clinic. So now I'm advocating, we must also take opportunity, assess inhaler technique, every single opportunity that we have in the clinic, because the technique can drop, can go, because it's not patient's fault, because it is just the nature is like that, because there's so many devices out there, each of them unique in a way, each of them require different maneuvers and all that. So, well, we must assess every single time to make sure the patient get the technique correct. It's very easy for little mistakes to slip in, I will usually tell it may take several tries to feel comfortable using your inhaler, but it does get easier with practice. Okay, so I do have few inhalers with me. Maybe I'll just show a quick one. So this one, what we call a metered dose inhaler. So there is a pressurized system, and you press, you can see the high velocity spray. So using this inhaler, a patient should inhale slowly and deeply. Slow inhalation, like breathing comfortably, slowly in a relaxed way. So this is what we call metered dose inhaler. Very popular also. So we also have other type of inhalers we call dry powder inhalers. But before that, I want to show, just now I showed spaces, valve holding chambers. This can be attached to your MDIs and patient can use. So the technique, the MDI technique can be improved further with spacer or holding chamber. Some has, some have mask, some do not have mask. This one without mask, just with a mouthpiece. It depends on the patient which one you want to give. Other type of inhalers called dry powder inhalers. There are many types. I showed you now. This is turbo inhaler. This is what we call NACU inhaler. So sometimes they say like siput, It's like many names. Patient call it many names. And this one is Ellipta, newer version, newer generation of dry powder inhalers. Okay, and sometimes for more severe patient, we add this inhaler on top of the preventer or control inhaler. This one we call soft mist inhaler or Respimat. You can see I think I have one here. Yeah. So this is Respimat. The thing is, you can see it when you press the button, load, after you load, you can see it produces a slow moving mist. So this one not for all. Usually we add when for more severe type of asthma patient, but as I can't show every single thing here because there are so many. So with the dry powder inhalers, patient need to inhale with a force, with a certain force, because with MDI, patient need to inhale slowly and deeply. For dry powder inhalers, they need to use they need to inhale forcefully and deeply. And for soft mist inhaler, this one, they need to inhale slowly and deeply. So there are actually quite a lot of things to talk about when come to inhalers, but I think then we will have to stay here until night, so I don't want to do that. And I know Dr. Sumithra also very busy. So back to you, Tanuja.
To be honest, doctor, that was an impressive fact. Thank you so much, Dr. Jaya. That was a great one. The next question is, we often hear about asthma triggers. What are asthma triggers actually, doctor? Let's have Dr. Sumithra to explain this question.
Yeah, thanks, Ms. Tanuja. So actually, so we have, thank you to my colleague, Dr. Jaya, for the very comprehensive talk on the management of asthma, the inhalers. That's actually, as he said, it's just a new world out there with a lot of updates, a lot of new things, and a lot of hope for our patients actually. So when it comes to asthma, so we know about how what are the things that actually comprise a good asthma control. So all the questions that doctors will ask you, or you can do the questionnaires yourself. So a lot of people ask about how do you control asthma. So what exactly do we do other than the medications? Is it just all about taking treatment? Is there anything else that we need to know? Is there anything else that we need to avoid? So interestingly, asthma actually has a lot of triggers. And in some cases, I actually saw a question in the chat box about whether asthma can be cured naturally. I mean, in some sense, no, but maybe in some sense, the answer could be a partial yes also. It depends on actually what triggers your asthma. So actually asthma is, as I said, the narrowing of airways, which is a response to the stimulus which is coming from outside. So these stimulus are the triggers. So the most common triggers are actually things that are there in our environment, like dust, just any form of dust. Some people could be cleaning their house and it's dusty, the surfaces are dusty, and then that can trigger an asthma attack in them. and a lot of actually dust mites. Actually, that is one important cause of actually asthma symptoms. So that's why we often ask, how often do you change your bed sheets, your pillowcases, the curtains in your rooms, because this is where actually dust mites can hide. And sometimes you will notice that, you know, some people, they do change them a little less regularly, and actually just by just doing some modifications, maybe just changing the sheets at least every couple of days, or maybe at least just every week, you can see a lot of improvement actually in their symptoms, and probably they don't need so much of reliever medications, and actually just overall improvement in the asthma control. Other than that, also weather, or actually I can say air temperature. A lot of people actually tend to be hyperreactive. Asthma patients tend to be hyperreactive to actually cold, dry air that's cold and dry. So especially you may see those people who are sleeping with aircon, because we know that our air conditioners actually make the air cool, and they not only make the air cool, because they also make the air dry. So in some cases, use of dehumidifiers to increase the humidity of air. Actually, in some cases, especially in some some children and some adults also, it can help to a certain extent. But then again, you need to be careful, because using humidifiers and increasing air humidity can also increase the risk of mold growth. Like, you know, fungus growing on the walls, most commonly in all the damp areas in our house, bathroom, kitchen, etc. So we know that mold growth is also one of a very important trigger of asthma symptoms. Other than that, also we usually ask if patients do have any other allergies, if they have any other allergies to seafood, which may actually point that they may have a sulfate insensitivity, which is also related to asthma. And also any other allergies per se, if they're having any allergic rhinitis symptoms. uh, you know, you awaken in the morning, and then you have a lot of teary eyes, and your nose is running. And so if we ask them and they say yes, I have all these things, and then maybe they are also having allergic rhinitis, which is also another common finding in asthma patients, also happens concurrently. And the interesting thing about allergic rhinitis is that sometimes it is not diagnosed because it's not known, or maybe we did not explore it with the patients and etc. So the interesting thing is that sometimes we keep increasing the inhalers, keep increasing the dose, we keep increasing the number of inhalers, but and maybe the technique is satisfactory, patient is using it, we are convinced, but you know, somehow things don't improve. And then we find out, oh, there's a very poorly controlled allergic rhinitis sitting there, which has not been addressed. So usually getting that under control will also automatically help in the control of asthma. So actually that's why these, and a lot of people can have different triggers, food, some medications also actually can trigger asthma. Sometimes beta blockers, angiotensin converting enzyme inhibitors. These medications are sometimes found to exacerbate the asthma symptoms in some group of patients. Even some eye drops, sometimes, not commonly. But so that's why it's very important that when maybe even if your doctor doesn't ask you, but if you feel that there's something that you're doing which you feel that triggers your asthma, you can always discuss it with your doctor, your healthcare professional, and maybe you can explore more further than that. So, of course, the other, as I mentioned earlier, is occupational, which we actually see in a large number of our patients actually who come in with occupational. And sometimes, although not always, sometimes we do recommend in this group of patients actually a change in occupation if it is possible. Because sometimes it is just so difficult to control their symptoms because we are not able to remove the trigger. And as long as they keep working in that environment, so it becomes very difficult. And sometimes in some cases where we feel that it will benefit patients, we do advise, if possible, to change in occupation. But I know that sometimes that is not always possible to just change our occupation as and when we like it. So that's why it's actually very important to know about our triggers. Other triggers are like cooking with a fireplace, cooking with kayu arang and all these things, which I think probably not so common in nowadays, but probably sometimes when older patients come and all that, we do tend to ask about these things. So actually these are the most common triggers. There are actually plenty of triggers, some that I may or may not have covered. And also in our hospitals, interestingly, in some group of patients, we actually have allergic testing available. We do it in some scenarios, especially just to identify and just to confirm the sensitivity, especially before we start biologics and etc. We usually do run these allergic testings. They are available, but we don't normally do this for all the patients because as long as we know our trigger, if we are able to limit our exposure to them, then that should also help together with the medical therapy that we are receiving. Also, the most important trigger that probably I didn't mention is smoking. So smoking itself, it is a huge trigger for asthma. And I definitely advise every single of my patient who comes in, whether or not they have asthma, to actually quit smoking, because as we know, smoking, not being judgmental, but smoking itself actually has so many health hazards. It doesn't matter actually if you smoke cigarettes, or some people actually they come and say, oh, it is just vape. And actually we found that vape actually causes more accelerated lung injury compared to even your normal cigarettes. So actually that is in a way it's much worse actually to consume vape. So we do advise to quit smoking. We also have quit smoking programs in our hospitals which can assist some patients. They are motivated but they just don't know how to do it. So it is we do refer them to all these quit smoking clinics to get the help that they need. Other than that, as I mentioned earlier, in adults, actually obesity itself can lead to some subset of dyspnea, which is sometimes can also lead to asthma. Sometimes it mimics asthma. So in this group of patients, actually we advise them for exercise. We may refer them to physiotherapy to get an exercise plan, and we advise them for modification in lifestyle and to reduce their weight. And we do see that actually with the reduction of weight, their symptoms do improve. So these are the things that actually we ourselves as patients, and actually we can be more aware. We can look out for these things, and actually when we remove all these triggers as much as possible, sometimes it's not always possible to remove dust and all these things out from our life. But as far as we try to control it to a certain extent, we will see that it will also help us to lead a good quality life with asthma, because I think that's the ultimate goal, that despite having this airway problem, that life should just go on as usual. In fact, as how Dr. Jaya mentioned earlier, somebody who's out on the streets should not be able to look at us and say, oh, you're having asthma. So that's what actually doctors aim for, and also what we hope that our patients are able to experience, because I think living with a respiratory condition per se is something very distressful, and it's very debilitating, and also probably it can only be understood by those who are having the symptoms actually. Yeah, so back to you, Ms. Tanuja.
Wow, doctor. This would be very helpful for everyone. Thank you, doctor. Last but not least, there are suggestions for asthma patients to get involved in self-management. What is asthma self-management? Let's hear it from Dr. Jaya on this one.
Okay. Actually, I'm trying to advocate this slowly in my practice, asthma self-management. So asthma self-management refers to the actions you can do for yourself to keep your asthma under control. These are tasks that individuals must undertake to live with asthma. So this is by definition. To do this effectively, you need to have good partnership with your doctors or healthcare professionals. You need to understand your asthma. You need to understand the mechanism of it. Not to the extent of medical student or pharmacy students. Just basic understanding what is asthma. You must know your asthma symptoms, and the most importantly, you must know how to keep track of the symptoms. And you learn about asthma medication, how to take the medication correctly, and also as directed by your physician or doctors. Make changes in your life to prevent asthma problems, avoiding asthma triggers. Um, some of you may be given what we call a written asthma action plan. Nowadays, we are advocating to use written asthma action plan. Actually, what is a written asthma action plan? Actually, this is a written document which we give to our patients. Includes directions about daily self-assessment, like how you monitor your symptoms. Usually, it comes in a traffic light color, green, yellow, and red. So green means you're all good. Your symptoms are not troubling you. You are actually normal right now. So we will actually write what are the symptoms to look for to qualify. I mean, basically, if you are green, that means you should not have this, you should not have this, you should not have this, you should not be using your reliever, you should be very comfortable. So that meaning green is normal, go. Traffic light also go, right? Green means. Okay. So then we will write in the green, I would say like green zone. So you just take your regular controllers and preventers, and we will write exactly how many puffs you need to take and all. Then the second column in the written asthma action plan is the yellow. So as we know, when you drive, you see yellow on the traffic light, you need to take like a caution and need to start to brake, right? But usually we will speed lah. You see yellow, you speed, but that is not the right way. Yellow, you should take some precaution. So we will do the same thing here. We will actually will write what are the symptoms where you actually when you fall under the yellow zone, and what you need to do when you have increased symptoms which put you in the yellow zone. Then final one, red, obviously that is the more danger one. So we will also explain, I mean, basically it's a written instruction, or what are the symptoms that you actually need to look, signs of danger. Some patient, not everyone, I think I have one patient, we give peak flow at home to monitor peak flow. So you can either use symptom approach or you can use a peak flow approach. But obviously symptom approach is very easy for us because in Malaysian patients, I think not many patients will actually keep peak flow at home. But why I gave that particular one patient a peak flow to monitor at home? Basically, peak flow is something that you blow into it and it will gives you the reading of your the amount of air you blow. So usually, if you get more than 80%, then you are good. If you're less than that, then you fall into the yellow, and or if very bad, then it'll be on red. But that's not popular. We don't really use peak flow based monitoring at home because main reason is patients do not have peak flow. Most of them, we will guide them based on symptoms. But I have one patient, why we gave peak flow, because that particular patient really couldn't assess the symptoms. That means they couldn't recognize the symptom, poor perceiver of the symptoms, until become really, really bad, breathless, until couldn't speak, couldn't do anything, want to collapse, then only realize, oh, I'm having asthma symptoms and I need to rush to hospital. So it's very difficult for us to have this symptom-based assessment for that particular patient. So we thought, okay, she's a very poor perceiver of symptoms. So maybe we give something more objective. So we give a peak flow, then we tell you, okay, now you see, if you're reading between this and this, you are good. If your reading is between this and this, you need to take your precautions. If your reading is below this cutoff, you need to come to hospital. So these are the things that now currently we are advocating, but I think we still have a lot of work to do because we understand even from our research, not many patients holding a written asthma action plan, I think, but I see an increasing trend. So in a nutshell, this written asthma action plan is actually which medication to use every day at home, which medication to take during symptoms get worse, and also importantly, when and how to call for help. Right, thank you.
Thank you, Doctor. That's really interesting and something everyone should think of. Hope these tips will be very helpful to manage asthma. Well, thank you so much to both of you, Dr. Sumithra and Dr. Jaya, for the super enlightening and informative sharing session. So, doctors, shall we proceed to the Q&A session? To all the participants who wish to ask any questions, feel free to drop them in the chat box, whereby the doctors will choose the questions to be answered. So, doctors, meanwhile waiting for the participants to ask their questions, I would like to ask some questions that were asked in the Google form that was released earlier prior to the topic.
Yeah, okay,
The
sure.
first question is, I'm 26 and single. I have an asthma problem. Normally, I will suffer from breathing if I climb stairs or walk for a long time, and mostly at night when I sleep. I'm using a Ventolin inhaler and I don't go to any asthma checkups. I will bathe in hot water in the morning and evening. My question is how to stop using an inhaler. After getting married, will this asthma affect my pregnancy or will using an inhaler have any problem to get pregnant? How to prevent myself from getting an asthma attack? What type of food should I take? Because I'm on my weight loss journey now. Well, this seems like an interesting situation question we have here. That was the question
Okay.
asked doctors. Doctors, you can answer that.
Yeah. So thank you, Ms. Tanuja. So I think this person is having quite a predicament. I do agree that the symptoms sound like asthma. It could be, but I'm just concerned that she is 26 years old only, and she happens to be taking a Ventolin inhaler, which I feel she may have picked it up over the counter because she says she does not have any asthma checkup. And she also mentioned that she's in a weight loss journey, which I assume that it may mean that she possibly could be a little overweight or a lot overweight, which we don't know the details. So actually, I can't really tell you what the correct answer will be because definitely we would have to this young lady has to definitely get to a doctor and get properly assessed because the first thing is, as I mentioned earlier, not everything is asthma. Even though it looks like asthma, it sounds like asthma. As I mentioned, there are a lot of other problems which actually can mimic asthma. So she needs a proper assessment. Actually, she needs to see a healthcare professional and be diagnosed properly and undergo testing, which is what I mentioned earlier, which is a pulmonary function testing. She may need some bloods to be drawn, and she may or may not need a chest imaging to be done. Because it's important it's important that she's diagnosed properly in the first place because she's a very young girl. So missing asthma will lead to a lot of flare-ups, exacerbations, and if she's not receiving the correct inhalers, because actually she's just using a Ventolin, which is a rescue medication, PRN, and we know that the latest guidelines actually do not advocate for this even in mild asthma. So actually, there seems to be a lot of red flags here. So the first thing I will advocate definitely is to see a healthcare professional, get a proper diagnosis. If your diagnosis suggests that you actually in fact have asthma, assuming that we go down that path, it means that whatever symptoms that you're having, you're not able to climb stairs, you're not able to walk, you're having more night symptoms, all this based on what I was sharing, that you would have known that actually it means that you're assuming that you have been diagnosed with asthma, it means that your asthma control is actually not good, and it is worrying, and you need to get help. You probably your medications, and we need to look more into your lifestyle, remove any trigger factors, and get proper treatment to be administered to you. So I think a lot of people may ask a similar question, that is, will asthma affect their marriage, pregnancy? I do see a lot of patients who are asthmatics, a lot of patients who are actually diagnosed during their pregnancy, because also pregnancy seems to be one of the triggers of airway hyperresponsiveness. But generally with good treatment, good inhalers, we also do prescribe inhalers in pregnancy. They are safe. And in fact, they are very safe and needed actually to prevent the exacerbations which can be harmful to both the mother and the baby. So with all this proper treatment, we actually see that a lot of patients who are asthmatics, they can have a very fairly normal pregnancies, maybe with just 1 or 2 mild exacerbations. We do see bad cases, but usually those we tend to see them in those who have not been taking their inhalers, or they just happen to have a concomitant infection or some other infections that causing them to deteriorate so badly. But in general, if you are an asthmatic, you shouldn't be too worried about getting pregnant, and with proper doctors follow up with proper medications, actually the symptoms can be controlled, and there won't be any much issues with you or your baby. And I think weight loss. I think she asked something about weight loss. I mean, it's good. It's good that she's doing. She seems to have identified some problems, and I think food. Probably, I'm not the best person to probably comment on that. Definitely, she should get meet a healthcare professional, because we do have service of dietitians and all in the hospital who can actually write out a meal plan based after assessing her individually. They can give an individual meal plan actually with how much of calories they need to take, how should they divide their carbohydrates, proteins and veggies. But just as a general guideline, what I can say is that reduce the amount of carbohydrates and limit also your proteins, and more of veggies and fruits. And also definitely, if it is possible, exercise at least 30 minutes at least 3 times a week, if it is possible. Of course, all these are depending on your underlying health problems, and if you need any further clarification, you do have to discuss this personally with your healthcare providers. So actually, if I can take one of the questions from the chat box, I think from Noor Raihan. I think about the asthma being cured naturally, I think I've spoke a little bit on that. So treatment, so actually don't be, I think most of the questions are asking about how to stop inhalers. Can we do it naturally? I understand that the prospect of probably taking medications maybe for the rest of your life sounds very scary. I do understand that. I think that anyone in that position will probably be feeling the same thing. But I think that as Dr. Jaya has mentioned earlier, these medications are actually not just around for a day or two. In fact, our COVID vaccines are new, but definitely our asthma inhalers have been there for decades. And we have studied them over and over again, and most of them, if not all, are actually quite safe. And the important thing actually to consider is the improvement that these treatment will actually give you, and how that you will be able to live your life with a newfound freedom after getting freedom from your asthmatic symptoms. Because I think that only asthmatics will be able to understand the limitations that they are facing on their daily activities. Some of them will be having exacerbations more than once or twice a week. They will need to go to the emergency, get an nebulization, and all these things, when it happens so often, weekly, some of them will need admissions. And this will be really disrupting to their lives. Children cannot go to school, adults cannot work, they need to take leave, they need to explain it to their employers. So I think that the important thing to focus on is that the medication, the treatment is safe, and getting treated properly can actually give you the freedom that you probably wouldn't have felt before with all your symptoms, and it can really, really improve your life. And as I said, the natural part of it is probably just trying to identify your triggers and remove it. If you feel that you are, get triggered by drinking cold water, then don't. And whatever you can avoid to some extent, I do understand that sometimes you cannot avoid every single thing. Or if you have to clean your house, maybe put on a face mask and try to limit your exposure to the dust as much as possible. Or maybe try to see if you can get someone else to help you to do it, something like that. And I think that should be that. And also coming to the second question, I think somebody asked about the nose feels cold and they couldn't breathe. Actually, I'm not exactly sure without a proper assessment. Definitely we need a proper assessment. Probably we need to examine your nose, throat as well, and your ear. But it could be that you also may be having something as simple as a blocked nose, or you could be having something like allergic rhinitis, or you may even be having asthma, which is very difficult for me to just determine, because I think the information is a bit limited, and definitely we have to speak more in detail and probably examine and do a few more things until we can get exactly what it is. But definitely I recommend that you visit a healthcare professional who can definitely direct you. So sometimes if you can't go to a hospital or a respiratory clinic, even you can go to a clinic kesihatan where they are able to assess you and do all these basic things and get you further care if that is required. And I think another question that somebody has asked is aspirin exacerbated respiratory diseases in Malaysia. Actually, in my practice, I have not yet really come across those people who actually develop respiratory disease which is exacerbated by aspirin. So I can't really speak too much on the prevalence of it, because as I'm not very familiar, but I have not really seen anyone actually who actually presented. I do see a lot of aspirin intolerance, as in gastrointestinal intolerance to aspirin, but a respiratory, probably I would say that not so much. But I probably have to look into the statistics before commenting further than that.
Thank you, Dr.
I
Sumithra.
yeah thanks, Ms.
Is there
Nanuja.
anything? All right. Thank you, Dr. Sumithra. I hope this answer has clarified your question. Next up we have, is asthma a disease one can have since birth?
Yes, actually, as I mentioned earlier, so probably that should have answered the question. As in birth, as in we don't, I'm not a pediatrician, so, but based on my understanding, actually they do not, many children actually cannot really be properly diagnosed with asthma. Probably we will just say hyper-responsive airways, and we can only probably get a better diagnosis once they're about 5 or more than 7 years old, actually, because only at that age they're actually able to properly perform a spirometry for us to get any useful information. But the predisposition to get asthma is of course there since birth, as I mentioned, with all the multiple genes which are being blamed, and then some maternal factors and also some perinatal factors. They are born preterm and those kind of things, and environmental factors are also probably can lead in that sense, yeah. But probably more things like genetic and all will predispose that, probably they would have this from birth, but they do not manifest until usually when they are probably about 5 or 7 years old. We don't really, I mean, we do see children like toddlers 1 or 2 years old with some symptoms, but we don't really label them as asthma during that age, because it's not because we cannot diagnose them properly yet at that age, from my understanding. And actually, just to take another question, I think there's a question about COVID vaccine. So I think, of course, COVID. So COVID vaccine and I mean COVID per se and asthma. Maybe somebody is actually curious to know. We do have a lot of because I'm actually working in hospital Kepala Batas, which is a fully COVID hospital. So the only thing we see nowadays are just COVID and COVID patients. So actually, a lot of our COVID patients actually come in with underlying or existing bronchial asthma. Surprisingly, I mean, it's a good thing. They actually don't really have any exacerbation of their disease even during the stay, even though they have X-ray changes, which is category 3 or category 4 disease. Usually, their asthmatic symptoms remain quite well controlled. And also, I think vaccination and asthma flare post vaccination, I don't think there's any correlation per se. We have not really seen this type of associations after the vaccination, unless probably the flare up is probably triggered to some other things like maybe anxiety or something, getting the vaccines and those kind of things. Maybe that could be the trigger for the asthma. But per se, the vaccine per se does not cause a flare up. of asthma actually after the vaccination. This is not any known association. And also coming to the point of vaccine, we do advise our asthmatic patients to actually get vaccinated. Unless you have any other contraindication or any other reasons that you specifically cannot get vaccinated, definitely those with asthma, they don't have, there's nothing to say that this group should be vaccinated. There's a question about asthma appearing after several years. Okay, because I think I'm not sure what exactly the context, but actually sometimes asthma, especially childhood asthma, it tends to be there until they reach about puberty, and then it sort of takes a remission maybe for a few years and all that. So I think this is the point that sometimes people take it that the asthma has been cured. But I think it's more or less dormant. It's just that in some groups of patients, they actually do reappear at a later date, probably in their early adulthood, or maybe sometimes it comes back when they're pregnant or when they have any other respiratory diseases, infections, and then it gets triggered and then it comes back. That's possible. So, to answer the question, yes, yeah. So because usually we see that most children, even when they're asthmatics, everything tends to quieten down when they're about the teen years. And then sometimes it can recur back in their adulthood, or they may just remain well.
Thank you, Doctor. Dr. J and Dr. Sumithra, I think there are new questions asked in the chat box.
Yes, I think that I've addressed, I think, most of it. Yeah, I think I've probably answered almost all of it.
There's a new question here with us.
Is there anything on the, yeah.
Sorry, Doctor?
No, I think there is a question in the Google Sheet, is it?
Yeah, there are additional questions, yeah.
Something to do with asthma attack or something. Where is my Google Sheet? It has disappeared. Can you read the question from the Google Sheet? But I think I have to agree with Dr. Sumithra just now.
Yes.
Because
but there are still,
say again?
so, but there are still extra questions asked in the Google Sheet, yeah. So I can read that questions now?
Yeah, sure.
Okay. What are the prominent differences between asthma in children and adults? Maybe Dr. Jaya, you could answer this question.
I think that's already explained just now by Dr. Sumithra, right? So that already been explained. Do we have another one? Yeah, the one with the acute exacerbation. Just check my Google Sheet.
Doctor, there is a new question in the chat box.
So what we all know that. Okay, Dr. Sumithra, you want to go first?
No, it's okay. Dr. Jaya, maybe you can go first this time.
I think before we go there, I think a very interesting point on COVID and asthma. She has brought up a very important highlight because when the pandemic happened, we thought our asthma patients is the one going to get it 100%, the full blow. Then surprisingly, they tend to be okay. So then I Googled and tried to look into why this phenomenon happen. Actually, there's a very interesting discussion going on among the pulmonologists. Actually, there's a new study from Europe showed that adherence to inhaled corticosteroid increased during the pandemic. So again, what this is telling us, actually, asthma patients have became very fearful of this pandemic. So without any intervention from pharmacists or doctors, they actually themselves start to adhere, taking their steroids properly because they want to take care more. They are worried about the COVID will come and get them. And I'm very surprised the adherence for the first time without any intervention, without any program, without any counseling session, adherence gone up, if not mistaken, by 70% or 20%. You know, like I was like, wow. So it tells us again the behavioral aspect of adherence and asthma. So actually, it's all a lot of behavioral changes need to be done for us to actually to treat handle this disease. And some also advocating that asthma disease itself, there is a down regulation of ACE2 receptors, and that is not. I mean, there's still preliminary, but you know they also have some discussion. And another study which I recently saw, even inhaled steroid when they used in the mild COVID was also shown to be protective to prevent them from progressing. I mean, these are still very preliminary results and studies, but it may explain why this phenomenon is happening. So, I mean, those are quite interesting. But I think those, I think we will look for more evidence in future, and hopefully we can share that in near future. So I think this question, we all know about asthma attacks occur out of the blue. So doctor, what could a person do when he or she senses that they are about to have an attack while waiting for professional help? Is that the one in Google Sheet? Tanuja, is that correct?
No, doctor.
Okay, then why is it appearing in my... Okay, so anyway, that is actually I think that's an important question as well, you know, because you are having an attack, a flare, what you need to do. And most important, for me, usually I tell the patient, you know, you don't panic, because that's very important. Stay calm, sit upright, calm down, then you can start using your reliever medication. Usually there will be increased use in reliever medication. If you have spacer or holding chamber, this is the really wonderful time to use it with your NDI, because we know during an acute event, it's a bit difficult to coordinate and meter dose inhaler alone. So when you have a spacer during acute event, you actually can have a better technique. And if you have asthma written asthma action plan, I think you need to start looking at it and follow the instruction. And of course, you get medical help as soon as possible. Other than that, is there any questions in the chat box?
Yeah, I think there's some question here. Okay, so hi, Miss Yashwini. Okay, multiple sclerosis. Okay, I'm really sorry. I can't take this question because actually I probably really need to know really more in details before I'm able to answer. And then because we know multiple sclerosis also is a very wide disease and wide range of treatment, and probably I don't think that it will be fair for me to answer here, and I wouldn't want to steer you in the wrong direction, so I apologize for that. So there's another question here. Some have asked that regarding the food. There's a few questions about food actually. So as I mentioned, these are also one of the asthma triggers. So food actually, interestingly, it can be quite varied. But food avoided by asthma patients, generally what we tell them to, generally we find that a lot of patients are actually sensitive to cold. Rather than cold food, actually it's more of cold drinks, cold water, cold drinks. We feel that we hear a lot of our patients coming and complaining that, you know, yesterday they had a cold Coke or cold drink, and then they got triggered with the asthma. So sometimes they know, they said, oh, yesterday I had that cold drink, so today that's why I'm having my symptoms today. So sometimes they do know. Other things, food, sometimes even things like actually they say sulfate insensitivity, that is like prawn or shrimp, dried food, preserved potatoes, these kind of things also. And I think that sometimes since it can be very varied, these are the common things actually we see causing sensitivities in patients. But sometimes even there are a lot of other triggering factors like chocolate. So sometimes you have to sort of go and experiment and sort of just like we would say probably keep a diary. Means be more aware of what you are eating, and try to see if there's any correlation, like especially when you drink a glass of ice water. Do you notice that when you do that often, that you tend to get more symptoms after that? And maybe when you take more shrimp or something, do you actually start to have symptoms after that? So that's how you can probably eliminate those things. Otherwise, it's very difficult to say that only this food will be causing, because sometimes that's the beauty of individuality, because sometimes things can be different for one person and another. But the most common food related triggers that we normally see are like seafood, shrimp, and also cold beverages actually. So I hope that helps. So if you feel that you can't have a cold drink or a cold meal, try to just avoid that, and probably you will get some improvement there.
Thank you, Dr. Sumithra and Dr. Jaya. Doctor, one more question is, can inhalers trigger cardiac arrest?
Okay. So far, I think we have not seen any evidence on that. But if you, the one on the cautionary note is when you are using too much of, the salbutamol, the reliever inhaler, right? So if you're having underlying cardiac diseases, sometimes some rhythm disturbance, sometimes you have some, shaking, tremor. This is still possible to happen, even though it's not really common. But in terms of pharmacology, if you overuse your reliever, the salbutamol inhaler to very high dose, sometimes some of these adverse reaction being reported in the trials. So that's another reason why we say that but in trial actually underlying most of the patients who develop this problem actually have some underlying cardiac abnormalities at the baseline, but it's not very severe, but it can still happen. So I think we still need to be caution on that, and that's why we always say the blue inhaler, we don't use it excessively. It tells you two things: one is your asthma is not controlled, or you may have developed some side effects related to the blue inhaler. So we take that as a cautionary note to our patient. But cardiac arrest per se, I have not come across yet.
Thanks, Doctor. There is a new question in the chat box as well.
I think somebody has asked about if asthma can trigger eczema. I think that was the question I saw just now. I don't think that asthma per se is triggering eczema, but it's more likely that in someone with asthma, actually, if you inquire further, if you speak to them, you will find that they also have coexisting eczema. So these are the few things that actually tend to come hand in hand. So they do have eczema, they have asthma, they probably can have some allergic rhinitis, but asthma per se does not cause someone to have eczema. And then there's another question: when asthma is uncontrolled. Okay, I think this is important question. So probably that's why we are doing this whole thing today, because we don't want anybody's asthma to be uncontrolled if it is possible. Because I think asthma, as you know, the symptoms I mentioned, that wheezing, cough, breathlessness. Sometimes it's easy for us to say these things, but unless you've actually felt breathlessness, then you would know how debilitating. Just try holding your breath for even a few seconds, not being able to breathe out. That sensation, that is what asthmatics are actually going through every single time that they have an attack, or they do not feel well, or they are not very well optimized. So whenever your asthma is uncontrolled, actually over the time, your lung function will be declining, and definitely your quality of life will be declining, because you are not able to perform at your full capacity. It goes so far to say that some people may not be able to sustain relationships, may not be able to sustain their occupation, And really it is can be, it sounds so simple like asthma. I mean, we don't really, sometimes we just say it's asthma, but sometimes it's only for those people who actually can feel the symptoms, feel the limitations of movement. They are the ones who really can attest to how debilitating the disease is. So when asthma is actually uncontrolled, each asthma attack actually over the times it will actually reduce your lung function, and actually over the times what I mentioned just now, it's a reversible airway narrowing actually. So but what happens if you are not properly treated, you do not receive your steroids and your medications, your inhaled medications, um, actually over the time we see that the damage has happened to the airways, and this damage becomes permanent and no longer is reversible, so it becomes irreversible airway damage. That's when that sometimes after that, even when you use your inhalers and all that, you will see that it starts to not work, because your inhalers actually work by causing the reversibility of the airway constriction, so they dilate the airways. But if the damage is already irreversible, it cannot be reversed, so then you start seeing that your medications are not working, and your lung function declines, and it can actually nowadays we don't see that kind of really bad asthma which has not been treated, because we have everybody is much more aware. They know how to seek treatment. We have clinic kesihatan, we have GP clinics. People can get information. They can get access to inhalers. So we do see that we don't have that type of really bad asthma that sometimes we even may need oxygen therapy, or maybe some those cases that we feel are lost causes. We don't see them much anymore. A lot of our patients, thankfully, they are not so bad. We do have very bad asthmatic patients, but actually with all the recent medications, we're actually able to get them under control. So the important thing is actually the decision also from the patient to get treated. And also asthma is one disease or one condition that patient has an equally important role as the doctor in their management plan and also treatment plan. Heavy exercises, yeah, actually if your asthma is controlled, you should be able to do moderate intensity exercises. It shouldn't be an issue, unless you are having exercise induced asthma, which is also one type of asthma actually, where your symptoms, somebody can be just absolutely all right and they only have asthma symptoms when they do exercise. And so in those cases, probably you have to look into what kind of exercises are the one inducing your asthma, and maybe you can try low intensity exercises like walking or just some light jogging first, and you can assess from there onwards. And probably with improvement of your asthma symptoms with proper treatment, you may be able to increase your intensity slowly, but probably just don't go in for the very high intensity exercises when you are having uncontrolled asthma and all that. That probably won't be a very good idea. Heavy extreme sports, again, it depends probably what kind of heavy or what kind of extreme sports, and because probably asthma, there's a lot of, as I said, triggers and all that. Probably anxiety and fear also can be a trigger to asthma. So it's difficult for me to really say whether it can be done or cannot be done. But anything, you can always discuss with your own healthcare professional to get a proper individual plan for yourself. And I think the most important thing is your own assessment to whether you will be able to do that. Because I think a lot of asthma patients actually they know themselves better than anyone. They know what are their triggers. They actually they are able to advise the doctors actually regarding their condition very well.
Thank you, doctors, for helping us to obtain a clearer understanding of this topic. I hope that everyone has acquired some knowledge from the answers provided by our guest speakers during the Q&A session. To sum it all up, that's all we have from Dr. Sumithra Appava and Dr. Jaya Muneswarao. We hope that this sharing session has enlightened all of you regarding asthma in adults. Dr. Sumithra Appava and Dr. Jaya Muneswarao, thank you for joining us despite your busy schedule. It was a huge privilege to have both of you with us today. So, we have come to the end of our event. The feedback and attendance form for my CSD will be given right after the photo shoot. Kindly please switch on your cameras for our photo shoot session.
Welcome. And I would like to thank everyone for the opportunity. Yeah.
Yeah, thank you everyone, and hope that you all enjoyed this session as much as we all did.
Thank you, Doctor.
Thank you so much, Dr. Jaya and Dr. Sumithra. So we will proceed with the photography session now.
Sorry. So, but did you take ready the photo shoot?
Wait, oh, just now you guys can't hear my voice, is it?
Yeah, take again.
Okay, now can. Okay.
Yes.
Okay. So sorry for the technical issue. So we'll be taking our photos now, lah. So 3, 2, 1. 3, 2, 1. Okay, that's all. Thank you, and sorry for the issues.
Yeah, thank you.
Thank you so much, doctors.
Thank you.
Let's put our hands together for Dr. Sumithra Appava and Dr. Jaya Muneswarao. To all the participants, we would like to convey our heartfelt gratitude for being here today. We would also like to apologize if there were any mistakes from our side in organizing this event. Dear participants, you can now scan the QR code displayed on the screen or use the link given in the chat box to fill in the feedback and attendance form for my CSD purpose. Please be reminded that the form will be open for 10 minutes only. If you think that there are some constructive feedback that you would like to give for improving the quality of our upcoming events, don't hesitate to drop them in the feedback form later. Thank you for joining us today and hope to see you all at our future events. Have a good day, everyone.